So today we're going to go over my in-service, which is going to be basically an overview on uh, what is it, how do we treat it, overview on femoral acetabular impingement syndrome, or FAI, FAIS, if you're interested in that other term. Uh, Basically, we're just going to run through it. Obviously, in the PT realm, we all kind of understand what it is or like how it works. But now we're just going to go into a little more detail on basically what that looks like for us and how we as PTs can help intervene and help care for these patients. All right. And then I'm going to be doing most of the talking. Vito is going to be interrupting, or at the end, if he has questions, sharing his questions with me, and hopefully I can answer to the best of my abilities. All right. So starting, we already know kind of what FAI is. It's morphological alteration of the femoral head, acetabular, or both. I have some images down there for reference on the types of impingements that can occur, and these are all bony issues. So a pincer is going to be more of the acetabulum itself, kind of coming over and engulfing the femoral head a little bit more. Okay, and that's going to be limiting more of a flexion moment. So hip is not going to have as much range of motion into flexion as it would with a less pincer type hip. And then a cam deformity is going to be essentially the femoral head becomes more of a teardrop shape as opposed to its regular round circular shape. And then with that, um, FAI could also be a mix of both. Okay. And that's going to be limited in most directions and the most limiting out of the impairment. And then I didn't mention it, but cam deformity is going to have more of a all around decreased range of motion, depending on where it is getting that teardrop shape, which can be variable depending on the type of positioning that it's taking. Any questions on that, Vito? Or is that all stuff that's review
That's
for
all a
you?
review.
Perfect.
But my question is, are a lot of or all impingements due to bony change, or can you have impingement signs without any sort of morphological change?
So you can have impingement signs like snapping hip syndrome. Those go into other diagnoses. FAI is specific to morphological changes of the bony joint. And if you get into like the soft tissue differentials, that is going to be other things in their own realm. And we'll talk a little bit about that.
Okay.
And then if you're able to see the doc that I have pulled up, you'll see that FAI is commonly associated with labral tears. And we'll talk a little bit more about that too, because that is going to be a huge differential diagnosis when examining these patients.
Sounds good to me.
Yeah. So some etiologies. I found a couple articles talking about it. Um, the big thing is that FAI is more of a multifactorial issue and is not a very one one point centered like issue. It's caused from a multitude of issues. Family history and like intrinsic patient factors like their genetics are going to be things that are obviously taken into account. If the family has a known hip issues, this is going to put them more susceptible to obtain this. Repetitive activities, as like young athletes may experience basketball, hockey, football, any sort of fast, heavy load and like same repetitive motions are going to essentially increase bone growth, which is something we kind of already know to be an issue or to be a morphological change in the body. Like as we add stress to bones, they form to that, and that's how we have all of those tubercles and all of those attachment points for muscles. So these are things that kind of make sense as to how it kind of forms. And also pediatric hip diseases, also lead to possible issues in the future, aka FAI. So slip cap femoral
Sticky,
epiphysis or late calf parestheses. I know, what a
sticky.
word. Femoral neck malunions or overcorrection of like a hip dysplasia. These are all things that when you consider you're a child or a child athlete as like issues they have, this is something that may need to be addressed in the future. And with that, I should caveat also that FAI is not necessarily something that needs to be treated, but symptomatic FAI is something that should be treated.
Okay.
Most people have naturally occurring formations of their hips due to just regular everyday life. And whether that's causing them pain is more the issue we want to address. Does that make
Yes,
sense?
it does.
All right.
We don't treat things that we
Now,
don't need to
going
treat.
into that, yes. So going into more of that presentation, they're going to have a lot of groin pain and just kind of do that V taper and it's probably describe it as more of a deep ache. It could be in the thigh or the buttock. And with that, you're going to be looking in for exams, SIJ dysfunction potentially, if they're reporting more posterior pain with it. You'll see an overall decrease of range of motion, and you'll have reports of either like a stiffness, a clicking, a catching, a locking, or a giving way. These are all things that may point you to that. I'm gonna leave a little asterisk when talking about the clicking because that's going to entail a couple other things on possible differential diagnoses with FAI. And then they're going to have a decrease in like ADL activities or just report like they're unable to like climb stairs well or they have trouble doing certain actions that involve a lot of hip range of motion. And then now going into exam. Before that, any questions on any of that presentation, patient presentation or etiology?
No, this
No?
is all stuff that
Cool, cool,
we
cool.
should be semi-familiar with. This, I'm gonna
Yeah.
appreciate a refresher on.
Yeah. So FAI doesn't have much special testing. The big things you're going to do is rule out extra-articular pathology, which you kind of had asked about, if it's like only pertaining to bony things. So tests you'll kind of pull in are going to be first Padir and Faber. Those are those big ones we kind of already know when addressing the hip. FAI is more specific to the first and Padir. And with that, the biggest thing is that a positive will be reproduction of their symptoms. And this is where your kind of clinical knowledge and being able to deduce type of pain is going to be very important because you're going to ask them like, how does it feel? Describe it to me. And FAI in particular is more associated with a pinch kind of feeling, if you will. Patient will say, like, oh, it just feels like something's really like pinching down there, or like it's like a deep pinch, things like that. And because it's highly associated with labral tears, the differential in that that may give you a little more notion to look at other things would be if they say like, oh, there's a click, like very much like it's clicking every time like you move it this way, and that's going to be more indicative of like a loose tissue body in there, aka their labrum. Like if it's torn, it's going to be free floating and possibly just flapping over other structures, which is the clicking that they're going to be feeling. And so other tests to help rule that out is going to be the McCarthy sign and the log roll. Log roll positive is just going to be excessive external range of motion. I don't know if you remember the log roll. Hold their heel, external rotation, and then let go and watch for the spring back. McCarthy is going to be where you're moving them up into flexion and adduction and then pulling them out. And one thing you can do with the McCarthy sign is do a passive, and that's going to be more indicative of interarticular issues, asking them about that pinching or clicking feeling, which whether they're having it or not. And then you're going to have them do it active and just help them through the motion. And if their symptoms are more onset by an active McCarthy's test, that's going to be more indicative of extra-articular. Think more muscular overlay, what tissues could be irritated in that area, and think more outside the capsule. And those are going to be good differentials for you moving forward. All right. And that's kind of the gist of other tests. Um, One thing I'm also going to mention, because I talked about SIJ dysfunction, with the Faber test, when the patient's in that position, if they're able to pinpoint their pain more posteriorly, think more SIJ
For which
dysfunction.
one?
So doing
Faber?
for the
Oh,
Faber,
yeah.
hmm flexion, abduction, external rotation, so like figure
Mm-hmm.
four kind of position. And if they're saying it's more in the back, you'll have them do the bend forward, checking for nominate rotation, things of that nature. I didn't include it too much in this only because I feel like that was too down the rabbit hole for what we're focusing on, which is FAI. But needs to be mentioned for the sake of mentioning all hip involvement.
Mm-hmm.
And now moving into more treatment and intervention stuff. So overall, there's not a lot of like high level evidence from what I've seen in a couple articles. There are some good articles addressing like this is like the gist of what you can do outside of surgical options, which I'm going to talk about surgical options too, that being either arthroscopy, acetabuloplasty, labral repair, if you do find out that it is a labral involvement and debridement, or femoroplasty. And two of those are just reshaping, basically shaving down that pincer or cam, whatever is forming and causing that issue. And then hip arthroscopy is just a whole remodel. And then going into more conservative management, bracing may help for impingement. And the type of bracing you would do is just like a limitation bracing and just stopping them from being able to move into whatever painful motion they're experiencing. And then education, I feel like that's such a catch-all, but the article described it blatantly as like patient education is huge because you want to promote them limiting their motion temporarily to help those tissues calm down and reduce irritation. And I think that's where you're gonna have a huge talk with them about like, okay, we don't want this pain. We have to move very particularly or just avoid the motions. Because if their issue is like, oh, it's only when I like kick across my body and it's like this very excessive sway in, it's avoidable.
Right.
And like, let's avoid it and let's slowly work like into that motion and not upset it.
Is
Other things that are gonna help are, hmm,
question, is there a
yeah.
timeline, or are you going off patient response for how long you want to limit their motion? And how do you educate on, so say it's a non-excessive motion, it's just a relatively normal motion that they will have to use. How do you educate and set expectations on how to limit that? And is it how, what does short term mean?
So I didn't see any reports about timelines for that sort of thing. It's going to be very like patient report for us, I think, and that's going to be kind of the balancing act that we play. Um, with that, if it's super excessive and it's just like it only hurts in these like very end ranges, and their lifestyle doesn't actually have them living in that position, then it's like, okay, we have a way to reduce this easily, unless they're an athlete and it's like, I have to do this. There's going to be more conversation around like limiting maybe participation for a couple weeks, seeing where they are in their season, if that's going to be an issue or unable to. Because then we're thinking of like short-term pain relief while also focusing on other things that we can do in conservative management, which is like hip stability, neuro-rehab, and movement patterns. Maybe finding ways that they can still perform their task while being able to reduce the amount of irritation that they cause while doing so.
Mm.
And I think that's where we as movement professionals need to come into play and really like re redesign how they perform and just seeing ways we can easily correct them. And then with that, uh, like hip stability, those are very generic things that we go over for most patients, I feel like. Range of motion is going to be a little hard only because if it's a bony like issue or a bony block, we're not going to be gaining much motion. And I think in that it's going to be more active range of motion, having them move into better movement patterns with that and promoting more muscle length and comfortability in that position from other tissues. Questions on more of that?
Nope, that was my
Or is
main
that good?
one.
Yeah. Okay. All right. So an article that I'm sharing also on top of all this, my clinic in particular does a lot of injection, minimally invasive injection. Um, our doctor on site really has a lot of good evidence behind using it. They do hip. I made sure to ask that way I didn't just like waste my time like on something that they can't actually utilize as a study.
Mm.
She does a lot more lower back injection, and the patients I've worked with that I've had the injections report very quick pain relief, and it's allowed us to make much further gains and help therapy and rehab go a lot further for them. And this article basically encompasses that model we kind of use already. And title, the effective femoral non-operative management program combining with hip injection with structured adjunctive exercise rehab in patients with symptomatic FAI, which is what we're kind of worried about. So study level 4 evidence. So not elite, but it's giving us a start on where to kind of turn our head, essentially. They wanted to see how FAI can be treated, whether that's injection, rehab, or combination of both. They had 49 patients all around, like 32, that went into the program. They had a couple outcome measures that they used, such as the International Hip Outcome Tool or Hip Outcome Scores and the Modified Harris Hip Scores. These are all ones that I hadn't heard of before and had to reinvestigate basically to find out what they were. But basically, they're just all patient reporters. And then as a result, so the ones that underwent the injection and the rehab, they did an 8-week program, which I'm gonna be switching my screens to kind of show you a little bit because they did give the program and like show us like what exactly they had them doing. And I think that's going to be a valuable tool for my clinic in particular to basically give them a baseline if they ever have this occurrence. And so they had 24 months for post-injection period, and basically they're following all guidelines and just measuring them at the end. Scroll down. So pretty much at the end of their study, they found that 32% of patients progressed towards surgery, but they had all significant improvement in pain, symptoms, and physical functions prior. And then the ones that did not progress to surgery basically had a very great result, basically avoided surgery and didn't have to uh, further involve themselves with more invasive care. So they were able to minimize that. So overall, it shows that rehab with a minimally invasive injection can produce a pain relief for the patient and promote better healing for them overall. And let me switch my screens over so I can show you this program. Share. Any questions?
No. Wait, hold on. Yeah, one more time. Final conclusions. The injections after the 4 weeks period. What were the results?
So they
Nuts
reduced
and
the
bolts.
amount of patients that were needing surgery, and they
Okay.
were able to improve on pretty much all outcome measures, which were pain, symptoms, and physical function.
Okay. That's what
And
I say. What was the measure? Okay. It was function, pain and
symptoms.
function. Okay. I'm there.
Good.
I'm with you. Yep.
Nice.
I'm just
Cool, cool, cool.
getting into a better position because I have to change positions. I'm getting my own pain.
So here's that 8 to 12 week program. So first couple weeks they're staying very, very low grade, very like high volume exercises. So like hip flexor and quad stretching, uh, external rotation with TheraBand, things that we're all pretty familiar with. Bridging, unilateral bridging or ball bridging, which kind of higher level on the ball bridge, but depending on how the patient is presenting, they may be able to do it if the pain is not within that range of extension. And then basically working on some glute med and more Therac with a freestanding squat. And then going into the next one, they move more towards weight-bearing exercises and ultimately like movement patterns and promoting more education in that. And all of these dosing parameters, they appear more to me to be like neuro rehab with the high volume and seeing how the patient presents in that way. Some stability exercises in this second phase, and this is all as I'm looking at the basically biweekly progression. It's giving me more of that like mesocycle kind of change up that we were talking about in the last episode.
Mhm.
And then also for those listening, I can share this article too if you're interested in like kind of getting a gander more at this article and the program that they use
Yeah.
because it's all pretty
Let's
helpful
post a
stuff.
link. Let's post a link to this in the show notes on Spotify and on YouTube, so that way people
Yeah,
can quickly access it.
cool, cool, cool. Sounds good to me. And then into, I guess we can call it third phase, they're doing more overall stability and some more cardiovascular training to basically revascularize and promote some blood flow to the area with the rower ergometer. And then they're having them do it for a long time, I think. If you're in a clinic, I don't think you're going to have 20 minutes to just do a row. But so I think that's going to be more subjective to how you feel with the
That
patient
could be,
or hmm,
yeah. I was gonna say you could also just be like, hmm, if they have access to one, we're gonna do 5 minutes here, and what you do is 20 minutes. Like you can assign it to some exercise.
that is true. That is very true, actually. Thank you for bringing that back up. Send them home with stuff, some of these.
Mhm.
Um, and this is going into more functional stuff in the 4 to 8 week period with the unilateral squat um, and the squat variations like the Y or star excursion tests. I think these are going to be more dynamic stability into more challenging. But at this point, I'm assuming the patient's already having a reduction in pain and is able to progress into these within reason. Obviously, they're not going full depth and more being smart about their body and knowing where they're moving. And then the last one, kind of following that theme of like weight bearing, more unilateral, and working on core and trunk stability. They go into higher level things like plyometrics, adding in box jumps, step ups, vertical and broad jumps. I think I think this would be interesting to be able to utilize in clinic because having that impact and seeing what kind of like forceful compression results with their symptoms. Because if a patient is at one point was symptomatic with FAI and is able to withstand such a forceful and high load on impact, I think that's marginally better moving forward for them overall. So 8 to 12 weeks is going to give you a good metric on where they're sitting overall.
Mhm.
And then other other things that they decided to do are like hop variations, uh, triples, crossovers, like the hopping protocols, all those sorts of things that we can utilize in clinic and show the patient to move a little better. And yeah, that's essentially it. And that is going to be my in-service for my clinic. I really hope they like it. I'm going to be weaning out a little more, getting a little more exact on what I decide to share with them. This is a
Yeah,
good practice for me for when that comes time.
I like it. You did a great job.
But yeah, that's FAI in a nutshell.
All right. I really liked that formulated progressions they used for the study.
Me
I will
too.
definitely be taking that and using that for people that I'm treating that are back pain, not indiscriminate back and hip pain. It's just a lot of good exercises with the progression
It
for
is.
force attenuation and weakness.
Yeah, I think
So
they made it for one thing, but I think it definitely cross over into other hip pathologies very easily.
I I probably use it with some of my runners. Like one of my cases is patellofemoral pain, and it stems from movement dysfunction and weakness of the hips
Bada boom.
and ankle mobility. So there's plug and play with a bunch of those.
Yeah. And so yeah, that's gonna be my in-service. I'll be throwing this up on our links for all the viewers if they care to give the gander. And then all of my notes can be up there too, just be a quick reference for people.
Yeah. I'll have you draft the show notes for this one, and we'll throw it in our Google folder with everything.
Cool.
All right.
And otherwise, that's gonna be it. Any questions, Vito?
Nope. Covered them.
Cool. All right, y'all. Thanks for listening to my in-service. Hope you enjoy. Next episode is gonna be Vito's talking about all of his stuff that he got going on, and just me asking questions and being a active listener. All right. Peace, y'all.
Till next time. Peace.